This presentation will focus on delirium. The learning objectives for this presentation includes defining delirium, discussing the epidemiology across healthcare settings, discussing the pathophysiology, identifying risk factors for the development of delirium, recognizing and diagnosing delirium strategies, and discuss practical treatment strategies once delirium is diagnosed. Our presentation is going to begin with a case study. Our patient is an 84-year-old female who lives at an assisted living facility. She has a history of dementia, atrial fibrillation, breast cancer, and urinary incontinence. She has been admitted to the hospital after a fall and has been vomiting coffee grounds emesis with dark stools. She is oriented on admission to person and situation, but not time and place. At the hospital, she was started on a PPI, AV fluids, and the Xarelto was held. On the morning of the hospital day 2, she began to yell at staff. In the afternoon of hospital day 2, she was sleeping quietly for 4 hours. Nursing staff reported poor sleep the night previous due to assessments and the early lab draw. Remember this case as we go through the next slides. The definition of delirium comes from the DSM-5 manual. According to the DSM-5 manual, the patient must display both disturbance in attention and awareness, and this disturbance needs to develop acutely and fluctuate in severity. In addition to these two criteria, the patient needs to display one of the following. The disturbance cannot be explained by a pre-existing dementia. The disturbance does not occur in the context of coma or reduced level of arousal, or there is evidence of an underlying organic cause. To highlight some important takeaways from the DSM-5 criteria, there must be a noticeable deficit in attention span and awareness as it relates to your interactions. These deficits are sudden in onset and noticeably fluctuate. The report that you may have is that symptoms occurred over the course of hours, and that the family or staff is reporting that the patient is at baseline one moment and the next moment they are not. Another important takeaway point is that the underlying dementia of the patient cannot explain the above changes. You as the provider must search for an underlying etiology to explain the changes that are occurring within the patient. We know that the occurrence of delirium varies across different settings. This slide lists the epidemiology of delirium in various settings that we see throughout the healthcare continuum. It is important to note that rates of unrecognized delirium remain unchanged over a 15-year span despite education on this topic. Rates of unrecognized delirium were 55 to 70% in 2000 to 2001 and 60% in 2015. We know there are significant consequences to a diagnosis of delirium. Delirium is expensive and increases healthcare costs for that patient. It is also devastating to patient outcomes, and persistent delirium can occur up to 6 months post-hospital discharge. Delirium independently increases the risk of death at least twofold for a patient. It results in a functional decline with a potential loss of independence and more than doubles the risk of a nursing home placement. In addition, delirium can cause an increase in the risk of dementia. The pathophysiology of delirium is not completely understood. It is thought to be the final common pathway of multiple mechanisms and can be described as acute brain failure. There are a lot of theories that exist, but the most common theory for delirium is cholinergic deficiency and inflammation. We will first discuss the cholinergic deficiency pathophysiology theory. This theory is supported because medications with strong anticholinergic activity can trigger delirium. However, medications that increase acetylcholine has not shown efficacy in treating or preventing delirium. So it is not possible to say that the cholinergic deficiency is the cause of delirium. There is a simple tool to calculate the cholinergic burden of a medication, which is available at the website listed on the slide. Next, we will talk about the inflammation pathway. During states of infection and inflammation, white blood cells adhere to the blood-brain barrier and can trigger disruption of the usually tight cell-to-cell adhesion. This disruption allows increased permeability across the blood-brain barrier, increased transport of white blood cells and peripherally released cytokines, and decreased perfusion and longer diffusion distances for oxygen. The result of this disruption leads to neuronal ischemia and death. Though this theory is supported by the pathophysiology described, we do know that delirium also occurs in settings outside of those of infection and inflammation. So the inflammation theory alone cannot describe the pathophysiology of delirium. Traditionally, we think of three subtypes of delirium: hyperactive, hypoactive, and mixed. Hypoactive is 50% of the cases. Usually, the hypoactive subtype of delirium is missed or underrecognized. The symptoms of hypoactive delirium is decreased alertness, slow speech, lethargy, and apathy. Hyperactive subtype of delirium is very easy to recognize and constitutes 25% of the cases. Symptoms of hyperactive subtype of delirium includes heightened arousal, restlessness, wandering, and can be aggressive behaviors. The mixed subtype is a combination of hyperactive and hypoactive. Recently, the literature has discussed two additional variants. There is a catatonic variant, which is an extreme form of hypoactive delirium, and the excited variant, which is an extreme form of hyperactive delirium. This is usually associated with abuse of some of the drugs. We now return to our case. Thinking about what you've already learned, what was her subtype of delirium? Going back to what happened with our patient, on the second day we stopped her medication and requested lab draws to be drawn after 8 a.m. to allow the patient to be able to sleep. The resident was also ordered to be able to sleep throughout the night without assessment unless needed. The Foley catheter was removed as along with any telemetry wires and modules. The IV was continued, but the fluids were stopped. The patient was also ordered to be out of the room 2 to 3 times a day and to be out of her bed for meals. The family was educated on reorientation of the patient and discussed with the staff to reorient the patient as well. As healthcare providers, it is important to recognize the risk factors for the development of delirium. Risk factors are categorized into predisposing and precipitating factors. Predisposing factors are usually inherent and intrinsic to the patient, and precipitating factors are usually extrinsic. Delirium will develop when the combination of these factors crosses a critical threshold. This means that if a patient has more predisposing factors, less precipitating factors are required to tip the patient into delirium. This slide lists the predisposing risk factors for the development of delirium. It is important for you as the provider to be aware of these predisposing risk factors and to identify if they are present in your patients. This slide lists the risk factors for the development of delirium. Medications will be discussed on future slides. It is important to note that anesthesia and surgery are both risk factors for the development of delirium. For anesthesia, the route isn't as important as the total dose when considering risk factors. For surgery, hip fracture repair as well as cardiac surgery have a higher incidence than post-elective non-cardiac surgeries. This slide lists medications that are considered to be risk factors for the development of delirium. It is important to note that many patients may be on these medications on their baseline. Because these medications are already put the patient at risk for delirium, when you combine them with additional risk factors such as surgery, as seen in the hospital setting, the patient has a higher risk for the development of delirium. As you are considering the treatment plan for your patient, this slide lists important concepts for the provider to be alert to. It is important to manage pain appropriately, as uncontrolled pain is a risk factor for the development of delirium. It is important to limit orders for bed rest unless absolutely indicated, and to avoid use of physical restraints. Use of indwelling devices such as Foley's should be discouraged unless it's indicated, both from an infection control standpoint as well as a risk factor for delirium. Acute exacerbation of chronic disease and acute illness are also risk factors for the development of delirium, so it's important for the provider to recognize these conditions and to treat them appropriately. In addition, it's important to screen your patient for any chance of withdrawal, as lack of drugs or withdrawal symptoms can lead to the development of delirium. There is a mnemonic that is used to help remember common causes of delirium. This mnemonic helps you to remember the concepts that were discussed on the previous slide. Using the word delirium, you consider that risk factors for the development of delirium includes drugs, electrolyte disturbances, lack of drugs or withdrawal, infection, reduced sensory input, intracranial concerns, urinary or fecal conditions, and myocardial pulmonary conditions. This slide lists the common signs and symptoms of delirium. As you review the signs and symptoms that are listed on the slide, it is important to remember the subtypes of delirium that we've already discussed, as well as the DSM-5 criteria. If you are considering delirium as a differential diagnosis, there are some key pieces of history to obtain. First, you want to know the onset of symptoms, both in timing as well as what symptoms were occurring. You also want to make sure that you're understanding if the symptoms were fluctuating and the time period as to when the fluctuations occur. You want to know their baseline mental status so you have a comparison. You want to ensure that you understand the patient's level of consciousness as well as their current orientation. It's important to understand if the patient is able to be distracted, if their speech is organized, and the presence of hallucinations or delusions. It is also important to review the history to determine if there's been any changes to medications or the treatment plan that may be resulting in the symptoms that is being displayed. You also want to make sure that you're obtaining an appropriate review of systems to determine the cause of the symptoms that you are seeing. The physical assessment will be driven much by the history that is obtained. You want to make sure that you're looking at the vitals and comparing them to the baseline vitals for the patient. Again, it's important to determine the patient's orientation and the level of consciousness. The rest of the physical exam is going to be driven by the information that is obtained through the review systems as well as the history. Providers need to order diagnostics for delirium based on the history and physical obtained by the patient. It is important for the healthcare professional to have solid rationale for the diagnostics that are being ordered. This helps to control healthcare costs as well as reduce risks of obtaining lab results that do not fit the clinical picture. Another important tool as you are assessing your patient who has a differential diagnosis of delirium is using a screening tool. The CAM has been widely used and has good validity for recognizing delirium. There are several different forms of the CAM screening tool. The CAM ICU can be used for nonverbal patients, such as those who may have had a stroke or some sensory deficits. The BCAM can be used for verbal emergency department patients. The CAM-S can help assess the severity of delirium, and the FAM-CAM can be used in the home setting. However, it is important to note that the FAM-CAM does have lower sensitivity. The CAM has 4 different components. They are listed on the slide. The 4 components include acute onset or fluctuating course of symptoms, inattention, disorganized thinking, and altered level of consciousness. For a diagnosis of delirium to be considered, the patient needs to have feature 1 and 2, along with either feature 3 or 4. In addition to the CAM, there are other screening tools that can be used to recognize and diagnose delirium. It is important for the provider to be aware of the tools that are being used at the facility and to be comfortable with use of these tools. It is also important for the provider to know the sensitivity and specificity of the tools, as well as the strengths and areas for improvement that is seen with each of the tools. When considering treatment options for the diagnosis of delirium, the most effective approach is to prevent delirium before it starts. As we have seen before, once the diagnosis of delirium is present, devastating consequences may occur. Non-pharm treatment options are methods that can help prevent the development of delirium. It is important to try to avoid changes in the surroundings and environment as much as possible. It is also important to maintain a normal sleep-wake cycle. So as much as possible, avoid waking the patient at night and avoid letting the patient sleep all day. It is also very important to reorient frequently by use of clocks and calendars. Even if the patient displays aggressive behavior, it is important for the provider to remain calm, minimize noise and distractions, and avoid arguing with the patient. It is important to ensure that if the patient is visually impaired, that use of eyeglasses is being considered. In addition, if the patient has hard of hearing, make sure the hearing aids are on and in place. You want to make sure that you are ensuring that fluids and food are provided regularly, and you want to surround the patient with familiar items. Pharmacological treatments, once delirium developed, can include the use of Haldol, Risperdal, Seroquel, and Zyprexa based on the level of agitation being displayed by the patient. It is important to remember to stop these medications once the delirium resolves. In addition to these, it is also important to use pharmacologic pain treatment management options to ensure that pain is well controlled. As indicated previously, prevention of delirium is the best treatment. It is important to maintain a normal sleep-wake cycle and limit medications which can cause delirium. It is also important to ensure that there is adequate fluid intake to make sure that the patient is not dehydrated. It is also important to monitor for infection and to remove any unnecessary tubes that may predispose the patient to obtaining an infection. Treatment of the patient should also include education for the family. The family should be reassured that the delirium diagnosis should be limited. Once the cause of delirium is identified and corrected, the patient should return to baseline. It is important to educate the family on how to redirect and reorient the patient. Having the family around may help the patient with symptoms as well. Family need to understand that medication should be used only if needed for aggressive behavior. It's also important for the family to understand that they should not take anything the patient says personally while in a delirious state. We end our presentation with our case follow-up. The resident slowly improved over the next 3 days of hospitalization. The EGD for the coffee ground emesis was completed without incident, and the source of bleeding was found and treated. Due to some increased weakness, the resident was transitioned to the nursing home for therapy with a goal of returning to the assisted living facility. We thank you for your time and listening for this presentation.